Hi, okay, my name's David Tuller. I'm at the University of California, Berkeley, and I've written a lot about MECFS over the years. Um, and so I was asked to talk for a few minutes about the biopsychosocial approach, or the rehabilitative approach, I guess, to MECFS, um, and how that relates to long COVID and the changes that have been occurred over the last number of years. So, okay, starting in, I guess, the late 1980s and early 1990s, a group of mental health professionals and others in healthcare were promoting the idea that people with chronic fatigue syndrome, or which had um, or an entity that a similar entity had previously been called myalgic encephalomyelitis, or ME. We're now calling that MECFS, even though we're not sure what it is, and it's probably multiple related syndromes. Anyway, um, at that point, it was being called by this group chronic fatigue syndrome after the Centers for Disease Control had called it that in 1980, late 80s, after an outbreak in Lake Tahoe. So anyway, they believed, or they proposed that this was an illness that people had, or a condition that people had, and that they basically had nothing organically wrong with them. They posited that perhaps they had an initial fever. It was clearly something that was happening after people might have had an infection, a viral infection, it seemed like. So maybe people had a viral infection, after which they were sedentary during this, and so then when they try to go back to activities, they feel exhausted and very tired, and so they think, oh my god, I still have this illness, I must still be sick, I have to go back to bed. Then they get back to bed, they get more deconditioned, they start to have sleep dysfunction because of the deconditioning, or because their circadian rhythm is off. They get depressed because of all these things. That leads to cognitive confusion. It accelerates or exacerbates their ideations of having an illness, and so on and so forth. And so basically, the idea is that they have a kind of vicious cycle of deconditioning and unhealthy or abnormal illness beliefs. I'm going to take these off. That sort of decelerate or degenerate into this condition that then becomes chronic fatigue syndrome, or as it might be, myalgic encephalomyelitis, which was the name that these people wanted to get away from. Anyway, they proposed, on the basis of this theorizing, that sort of a combination of cognitive behavioral approach to help alleviate people of the dysfunctional cognitions of having a continuing pathophysiological disease that was causing them to have relapses. So they needed some cognitive restructuring to alleviate them of that idea, and or they needed a graded exercise therapy program. In other words, a sort of steady increase in activity to recondition them, essentially, basically, and to prove to them that they weren't going to have relapses if they just did little by little increases in their activity. They'd get gradually reconditioned, and this was the basis of these two therapies. Now, they did small studies in the 90s, and it seemed to show that these treatments might be somewhat effective. But these studies were all first fairly small and also very flawed, because basically they were all unblinded studies, meaning that everybody knew what treatment you were getting by definition, because it's hard to mask these treatments, unlike a pill, which you can have a placebo pill that looks the same. And at the same time, they were relying solely on subjective self-reported outcomes for their reports of success, or at least largely on these self-reported measures, specifically measures of how fatigued people felt, and measure of how what physical function. And these tended to be the two main measures that were used in some of these studies. And so these reported positive results. And so then in 2007, based on these and sort of related studies that seemed to show these treatments worked, NICE in the UK, the National Institute for Health and Care Excellence, published guidelines that indicated that they felt that CBT, cognitive behavior therapy, and graded exercise therapy were the optimal treatments for chronic fatigue syndrome, as it was named at the time, or I think it was chronic fatigue syndrome / myalgic encephalomyelitis in the 2007 guidelines. That committee was basically stacked with people who supported this paradigm and, were sort of involved in it to a certain degree, or at least some people. And so it's hard to say that it really probably did not get a very robust argument from, authorities that people were respected at that time. So after that, when that guideline was being developed, a trial had already started in the UK called the PACE trial, and those first results were published in 2011. And this was conducted again in the same way. It was unblinded. They had 4 objective outcome measures, but they didn't really pay attention to those when they finally published the results. Anyway, the first results were published in 2011, and based on these findings, the authors reported that cognitive behavior therapy and graded exercise therapy seemed to be successful in helping a significant number of patients improve, and this was publicized widely all over the place. This was in The Lancet, so it was a major journal. Colleagues of the authors published a commentary in The Lancet that said that the patients met a strict criterion for recovery, which was absolutely not the case. But these things were all published. The patients had pointed out and continued to point out major flaws in the study. These gradually have become apparent over the years. But in any event, at that time, the study in 2011 was used to sort of reinforce the PACE, the guidelines that NICE had published in 2007. They were used to say, oh, see, those guidelines were correct, and we don't need to make any changes. So then what happened is, from 2015 on, I would say, there were significant changes in how the treatment was viewed. In the U.S., the Institute of Medicine came out with a report. Now that's the National Academy of Medicine. That was very influential. The National Institutes of Health came out with a report that it had also commissioned. Both of these reports indicated that, they didn't rebut PACE in so many words. They didn't, I don't know if even mentioned PACE specifically, but in any event, the result was clearly a repudiation of the PACE idea that patients had nothing wrong going on pathophysiologically, and that this was all a function of deconditioning and sort of misguided beliefs about having an illness, because they basically both stated, these reports, that this was a serious, physiological illness, that people were very sick, a lot of investigation had to happen to find out what was wrong with them, and so on and so forth. There was also started to be a much more attention paid to patients. I published in 2015 a 15,000-word investigation of the PACE trial after these reports had been published in the fall of 2015, and then there also was a court case that was being pursued after that, which resulted in 2016 in some of the raw PACE data being released. The authors had basically declared success, but they had not reported their outcomes as they had actually proposed and promised in their protocol. This became a big bone of contention. When they finally were forced to release their data under a court order, and after Queen Mary University of London had spent £250,000 trying to prevent the release of data that was actually created using public funds, because that's where the research came from, it was funded by government agencies, it was clear that they had manipulated their data, they had changed their outcome measures, which we knew, but they had not released what their results would have been under their original measures. And it turned out that they really had no results, basically no significant measurements, or they had no measurements that amounted to anything, let's say that. They had minor measurements in some ways of measuring things, but they were so minimal as to be obviously induced likely by placebo, because people were told these treatments would work, and because of the subjective bias inherent in the study design. In any event, after all this and a lot of work on the part of amazing patient scientists and analyzers, and an increasing large number of experts outside the patient community, and experts from leading universities and elsewhere starting to look at the debate, it became clear that these guidelines were wrong, and that the respect accorded to the PACE trial and related research was misguided. In any event, this resulted in finally in last year, after finally reviewing all the new studies and so on, and going through a very extensive 4-year process, NICE published new guidelines that basically undid the previous recommendations and recommended against graded exercise therapy in the form that the PACE trial studied it, and all the data, the trials had studied it, which was basically that you have a steady increase in your activity program. They recommend five certain increments that you should go through, and you should not pay attention to the fact that you're having symptoms, because those symptoms are just related to deconditioning and so on. So that was recommended against, and any treatments based on the deconditioning model. And also, while it allowed for cognitive behavior therapy as a supportive measure, as it also allows for forms of exercise as supportive measures, it recommended against cognitive behavior therapy based on the notion that patients have dysfunctional beliefs or abnormal beliefs or unhelpful ideations about their illness. It also recommended against the notion that either of these or anything should be recommended based on the idea that they're recovery methods, because the data simply don't show that people recover from these things. Some people, the studies that show recovery are uniformly flawed, including the PACE trial. So in any event, these were undone by the 2021 guidelines that were released. Now, why is this important for long COVID? It's been clear from the beginning that long COVID, it was very early on in March or April, that people involved in ME/CFS recognized that there was likely going to be quite a long-term post-COVID pandemic of chronic illness of some sort, or a certain number of people, percentage of people, were going to have chronic complaints that were likely going to be nonspecific in terms of hard to link to any specific cause, and possibly resemble those that characterize ME/CFS. That's in fact turned out to be the case. So with long COVID, a certain percentage of the patients who are classified as long COVID is sort of any symptom, continuing symptom, I think 4 months or 4 weeks or later after the acute infection. So that encompasses a broad number of people. But a certain number of them, and not an insignificant number, have the same cluster of symptoms or a similar cluster of symptoms, post-exertional symptom relapse or symptom exacerbation, also called post-exertional malaise, these sort of profound relapses, cognitive dysfunction, often called brain fog, problems in memory and concentration and the like, some forms of orthostatic intolerance, dizziness and standing up, and other issues related to autonomic responses. These things are common in long COVID, just as they're common in ME/CFS. And so there is a clear overlap of some sort. What exactly it is, we're not 100, they're still investigating. But it was clear that the chronic fatigue, the ME/CFS guidelines coming out in 2021 were going to be viewed as a proxy for how to treat long COVID, and the same people, even though there are also long COVID NICE guidelines, but put those aside for a minute, it was clear that this was going to be looked at as a proxy, and that the fight over these guidelines really became, I think, a proxy war over long COVID, because long COVID is another opportunity for the same people who have long promoted in the UK, but in other countries as well, including Australia, who have long promoted the CBT-GET ideology or treatment paradigm. We're going to use long COVID in the exact same way, and sure enough, that's happened. There's been studies about long COVID and false, about ideations about having long COVID and cognitive behavior therapy and exercise therapy studies that do not mention in their protocols that they need to screen for post-exertional symptom exacerbation. They sometimes, when these are pointed out, it's been claimed, yes, we're screening for that, but if you don't mention it in your protocol, you don't mention it in your study design, it's hard to see that you're actually really taking it seriously. So basically, there's a whole now movement devoted to treating a much long COVID as ME/CFS has been treated, which is as a uh, largely psychogenic or largely psychosomatic, depending upon what word you want to use, or somatic complaints based on anxiety, in this case, anxiety around the pandemic, anxiety around long COVID, hyper focus on symptoms that you might have that really are just normal symptoms, normal bodily sensations, but you over focus on them, so you're making them worse, that kind of thing. So there's all sorts of treatments, all sorts of studies and treatments proposed for long COVID now that are sort of this template that was used for ME/CFS, and which in my mind has been debunked, and by NICE pretty effectively, is now being applied to long COVID. One thing I'll say is that in the UK, after the NICE guidelines and before it came out, when it was clear kind of what they were going to be, there was a lot of contention around them, and there still is. And there's some of the trade associations that call themselves royal colleges. These are trade associations of doctors of different kinds of specialties who look out for their own financial and interests, as any trade association does. They're essentially trade unions for doctors, but they're called royal colleges. I'm not sure what they're called in Australia. Probably something similar. So, given the highfalutin name, they sound like they're something special, but they're not. They're just groups of doctors who are arguing for their interests. Some of them have protested the new NICE guidelines, and they say that the committee was dominated by patient interest, which is simply not the case. There were some patients on it, as there should have been, but there were only 5 patient representatives on it. And there were, so basically, they're proposing that NICE did everything wrong, and the way NICE evaluated the literature was all wrong, and so on and so forth. So they can say that, but the fact of the matter is, the bottom line is that NICE has published guidelines in October 2021 that effectively dethrone the CBT-GET paradigm as the standard of care in the UK. And that means, because the NICE was looked to for a long time as sort of proposing the standard of care, that means elsewhere they need to be reconsidered where they are still considered the standard of care. That's happened a while ago in the US, but I think in other countries as well. And so that's my talk. I think I need to, this is the first time I've actually done a talk to myself, but I guess I will stop now. Thank you very much for listening. I'm trying to keep it within 15 minutes. I may have gone over a couple of minutes. I am sorry if I did. Thanks very much. Bye.